Okay, welcome everyone to this ERN-RITA webinar on COVID-19 vaccination for primary immunodeficiencies and rare autoimmune rheumatic diseases. My name is Johan Prévot. I'm the Executive Director of the International Patient Organization for Primary Immunodeficiencies, IPOPI in short. I'm also a member of ERN-RITA's network board representing PID patients. It's my great pleasure today to host this webinar on a topic that is, of course, being looked at extensively at the moment, and which I'm sure will yield a very interesting discussion. I'm delighted to see many attendees already. It keeps counting, so we have at the moment close to 120 people with us coming from healthcare professionals to representatives of patient organizations as well. And with us today, we have two great experts in the field of primary immunodeficiencies and in the field of autoimmune rheumatic diseases, who will provide us with their perspectives on the different COVID-19 vaccines which are being rolled out to the general population. And they'll go on as to how specifically these vaccines should be approached when it comes to these patient populations that we have just mentioned. Firstly, I would like to welcome Professor Alain Fischer, who needs little introduction. In fact, his main research interests are gene therapy, primary immunodeficiencies, and the development of the lymphoid system. Professor Fischer has held various roles during his career as the director of the Paediatric Immunology Department at Necker Hospital in Paris, the director of the Imaging Institute for Genetic Diseases. Professor Fischer also served as professor of pediatric immunology at the University of Paris Descartes and is presently professor at the Collège de France. Professor Fischer received the Louis Jantet Prize for Medicine in 2001 and the Japan Prize in 2015. He is a member of the French and the US National Academies of Science and Medicine. And of course, he was recently appointed by the French government to lead France's COVID-19 vaccine strategy. Professor Fischer, welcome.
Thank you, Johan. Good afternoon to everyone. So during my...
And I will perhaps just before you start, Professor Fischer, I will introduce the second speaker, and then we will go into the two presentations. Our second expert today is Professor Elkayam, who is head of the Department of Rheumatology at the Tel Aviv Medical Center in Israel. Her main clinical fields of interest are vaccination in rheumatic diseases, spondyloarthritis, and interventional rheumatology. Professor Elkayam is the past president of the Israeli Society of Rheumatology. She's a leading researcher on the effect of vaccinations in autoimmune diseases, chair of the EULAR task on vaccination in autoimmune inflammatory diseases, and one of the architects of the Israeli Registry of Rheumatic Patients treated with biologics. Professor Elkayam, welcome to you as well. With introductions done, we will start shortly our webinar. Please note that you are encouraged to ask questions to the speakers. You can see on the side of your screen a questions tab, and we encourage you to pose your questions during the presentations. After the two presentations, we will discuss a selection of questions with both Professor Fischer and with Professor Elkayam. So this time, Professor Fischer, the screen is yours, and we look forward to your presentation.
Thank you very much, Johan. So I have to show my screen again. I had it, but now I don't see it. Here it is. Great. So I'm going to discuss in general terms, what do we know about the anti-COVID vaccination and application to this vaccination to patients with primary immunodeficiencies, PID. I remind you just to start with that the cause of COVID is SARS-CoV-2. It's a coronavirus with a single strand RNA here. Is shown as the rubber here in purple. In this coronated virus with the spike protein at the surface, which plays an important role. The SARS-CoV-2 is a member of the family of beta coronaviruses, which includes two other viruses that have caused bad epidemics recently, but more limited than SARS-CoV-2. And it's known that There are zoonoses, so the virus comes from that, probably with an intermediary animal, and then end up in humans. So we have some information that are important in the perspective of vaccination. So the virus shown here binds to the cell surface of cells that they are going to infect through the S1 domain of the spike protein, which is shown again here on this part of the slide, and it binds to a molecule named S2, which is the receptor and enables the virus to enter cell and infect cells. So a key molecular interaction is between S2 here in green and the binding domain to the receptor binding domain of the spike protein. And obviously the immune response has a role to play, at this interface to neutralize the virus and inhibits this binding and hence infection. So as you know, the virus targets epithelial cells as the first priority cells from the oropharynx, where the virus replicates at maximum, but then it can go to the lungs, as you know, and of course it can also infect the intestine with intestinal symptoms in some cases. But on top of that, there could be also infection of the heart cells or the vessels, for instance, and some other organs. So it's a multiple disease, and we know that the disease can be benign with a good control of infection and emergence of antibodies and T cells, and or can go worse, unfortunately, in older people and in the some immunodeficient people where the disease is severe with high replication of the virus, poor T cell response, for instance. So what about the vaccine in this context? So within the last year, there has been a very rapid and very impressive development of several vaccines. So based mostly on inducing an immune response against the spike protein, shown here again, so from the virus. So there are several strategies. The first one that has been developed and is mostly used up to now is based on RNA vaccines. So the RNA encoding the spike protein is encapsulated in nanoparticles and used for vaccination. A second strategy is based on vector that includes the DNA encoding the spike protein, and these are mostly vectors made of adenoviruses. But there are also an additional strategy not yet in use, a part of clinical trials, which is to have the protein itself produced, combined with an adjuvant and injected. There are a few more, like inactivated vaccines, that can be used too. So what has been absolutely remarkable is that within 1 year, these vectors have been designed, they have been tested in preclinical models, they have been tested in clinical trials up to phase 3. They got authorization from agencies in the US, Europe, or elsewhere. They were produced at a very large scale and administered. So today, as a summary, we have the Pfizer and the Mrna in many parts of the world, not everywhere, and we expect to soon a third mRNA vaccine from the company named CureVac. In terms of adenoviral vectors, we have the AstraZeneca. Now we have the Janssen, which is in use in the US and will be soon in use in Europe, and will come later, June, the Novavax product, and in the second half of the year, the Sanofi product. So these are the main vaccines. Forgotten here on the adenoviral is the Russian one. I will talk about it a bit later. The Sputnik V, which is also based on adenoviral vectors. So let's talk quickly about the Mrna vaccine. So the mRNA, which is single strain, is included into nanoparticles. So these nanoparticles are injected by IM, intramuscularly, where in cells the mRNA is free, can induce the synthesis of the protein that is expressed and can be recognized by the immune system. In more details, this is more complicated, but the same principle, using these lipid-coated structures, nanostructures, injected in the body, and then debris and so on, and products of RNA can lead to the expression of the protein that is incorporated into so-called antigen-presenting cells or dendritic cells that are presenting antigens to lymphocytes to get an immune response, the T cell and the B cells to make the antibody. So this is the principle. And this principle works. These are the results of the clinical trial, the pivotal clinical trial that shows that in comparison to a control group who got a placebo, and those guys get infection one after the other. This is the cumulative incidence of infection over time. Whereas those who got the vaccine passed the first 10, 12 days, shown here on this magnification of the initiation of the curve, they are protected and there are very few infections. So the overall rate of protection in terms of infection induction is 95%, which is remarkable and now shown to be stable. This is the same as Moderna. These are the same kind of curves. So the incidence rate of infection is very low as a function of time compared to the placebo groups. And today we have the data from Israel. Israel has been the pioneer in developing extensively the usage in the population of such vaccine. And for instance, one of their publications in the New England Journal of Medicine, about 600,000 people who were vaccinated between December and February 1st, confirmed the very impressive efficacy of this vaccine in different ways, comparing again in blue the vaccinated people, in red the unvaccinated people, in terms of cumulative incidence of PCR positive events. So there is a protection starting from 2 weeks post the first injection. I remind you that there are 2 injections at 3-4 weeks interval. Protection against disease, protection against severe disease, here hospitalization, very severe disease, and protection against death. So overall, more than 90% protection with a very good tolerance of this vaccine. And so, which is, of course, very good news. So in terms of safety, this is a good vaccine. There is a low-grade reactogenicity, that is early events in the first 48 hours following injection. There are rare cases of anaphylactic shock in the order of magnitude in 1 in 100,000. This is a very special complication that occurs in predisposed people, but it's extremely rare, and there hasn't been any report of development of autoimmune diseases. So what about the adenovirus-based vaccines? So in that case, the adenovirus is here. It contains DNA that includes the DNA for the spike. So again, these particles are injected intramuscularly. They are captured by dendritic cells, where the DNA is recognized by receptors that induce an innate immune response, so the adjuvant effect of the vaccine. But also the antigen is presented to the B cell and the T cells first, the T cells and the B cells, so in order to get the T cell and the B cell responses to the spike protein from the SARS-CoV-2 virus. So in general, what do we know about the efficacy of such vaccines? So first of all, I'd like to remind you that before being used for SARS-CoV-2, it has successfully been utilized to prevent the development of the Ebola infection in Western Africa some years ago. So today, the vaccine includes the spike encoding gene that is modified or not, depending on the vaccine. So there are 3 candidates that are presently used. The one from the University of Oxford, developed by AstraZeneca, which comes from an adenovirus of chimpanzee. I will discuss it a little bit more in a second. There is the product from the Janssen company, which is a human adenovirus, number 26. And it is proposed by the company that maybe 1 dose will be sufficient to get protection. I'm not sure this is absolutely true in the future. We will see, but at least the protection against infection of 72% was achieved by this strategy. And the Russian vaccine, combining 2 injections of 2 different vectors, so this is the Sputnik V vector, provides protection at a high level comparable to the Mrna vaccines of around approximately 92%. So the most advanced, the one that is being used most extensively in the world is the AstraZeneca one, where individuals got 2 injections at 12 weeks intervals with a good efficacy, a very nice prevention of hospitalization, sorry for the mistake here, over 90%. And the data in the UK, where the vaccine has been used first, have confirmed the clinical trials with a very good profile of efficacy, so which is good news. And by the way, it's a vaccine that is stable at 4 degrees, so it can be easily used, whereas the RNA vaccines need to be frozen and they are a little bit more complicated to deliver. There is quite a sophisticated logistics. There is some concern I have to briefly mention about the AstraZeneca vaccine. First, there is a strong reactogenicity in young adults. Well, it's not too bad, but it has to be done. More significant is the recent recognition that this vaccine rarely, but significantly, can lead to deep venous thrombosis associated with thrombocytopenia and autoantibodies that cause platelet aggregation. This is mostly observed in people below the age of 50 or 60. This is why in several countries, like in France, for instance, today, this vaccine is only recommended for adults above the age of 55 or 60. We do not understand the precise etiology of this manifestation, but it has to be taken into account into the usage of that vaccine. So let's shift now to application of these vaccine products to primary immunodeficiencies. So are there primary immunodeficiencies or genetic diseases of the immune system who are at extremely high risk of developing a severe disease, severe COVID? Sorry for the I missing here. The answer, surprisingly, is that there are not so many. This came as a very good surprise, but still there are some. And the most obvious ones deal with the production of interferon. So interferon is produced by cells that are infected by SARS-CoV-2 through a signaling cascade, detection, transmission, and response interferon production that can lead eventually to the synthesis of many molecules that are required to control the virus. So we know today, I will skip that, I can go, sorry, directly to this slide, that thanks to the work of Jean-Laurent Casanova as well as the Dutch group, that rare individuals who have mutations, loss of function mutations in genes that are involved in the induction of interferon production, like TLR7, TLR3, TBK1, RF3, IF7, excuse me, they lead, and also interferon receptor, they lead to severe COVID-19. So these are very rare cases, but those patients are at high risk of infection. So if they have been known because of previous infections, which is rarely the case, but there are a few cases where it is so, then there is an indication, of course, to immunize these patients, whatever their age, as quickly as possible. So are there a priority for vaccination? Because of their genetic diseases, there are other risk factors for low interferon production. Yes, so genetic defects in interferon production, but also there is a group of patients, maybe I can go back here. We know that among patients with severe COVID-19, approximately 10% of them have autoantibodies, surprisingly enough, against interferon. And among those, there is a rare group of patients with primary immunodeficiency who are making such antibodies. This is the case of patients with the APC syndrome or AR deficiency, as well as those with mutations in the gene, excuse me, encoding the NF-kappa beta 2 factor. So those people are eligible with high priority to vaccination. If we go now about adaptive immunity, where we know that there are T and B cell responses shown here during the course of the SARS-CoV-2 infection. We know that there are antibodies, they are persisting for months. These are, of course, in healthy people here. The memory of the infection is quite good in terms of antibodies, in terms of T cells, in memory T cells. So there is a rationale to consider that people who have a deficiency in either T cells or B cells, or many, accounting for many primary immunodeficiencies, might be at risk for severe COVID. But actually, as I just said, it might not be the case as importantly. There has been an international study conducted by Isabelle Mates in Belgium and Stu Tanguy in Australia. They have collected cases of primary immunodeficiencies among the 420 that are known, who have been infected by COVID, and look at the results who had a severe COVID infection, and more than 100 cases were collected. And the big surprise is that among patients with defect in T-cell immunity, so shown here with cytotoxic T cells, there is nothing that came out. Of course, this is still a limited number of cases, but this was quite surprising. And perhaps even more surprising about B-cell immunodeficiencies. In this series of patients, there are 9 patients with agammaglobulinemia because of, say, X-linked agammaglobulinemia, for instance, and they had a benign course of COVID, despite the fact that they were unable to make antibodies. To be complete, I have to mention that a few others have developed not severe, but relapsing COVID, which is probably an indication to use antibodies, monoclonal antibodies, to get rid of the virus in such cases. But the only patients with B-cell immunodeficiency who had a severe course of COVID-19 were those with comorbidities, for instance, elderly people with severe lung damage, but not younger patients with no organ damage. So this is good news, and that indicates that the risk of severe COVID is not as high as it was anticipated at the beginning of the pandemic, indicating that there is some obvious redundancy of the immune system here. So what about the priority for vaccination in this context? Well, I would say PIDs with additional comorbidities caused by the disease itself or independently of the PID if they have, for instance, syndromic primary immunodeficiencies with affecting different organs. So there are obviously additional questions I would like to briefly discuss or address. Is it useful to vaccinate people who do not make antibodies? The answer is yes. They may be not high priority, as I just said, but it would be useful to vaccinate them because besides the B cells, there are the T cells, and it's certainly important to have a good T cell response to the virus. So it may be not fully protective, but this may protect these people. So they should be vaccinated. Is there any specific risk of vaccinating PID patients? The answer is no, because all of the vaccines that have been developed so far are RNA, proteins, pieces of DNA, so they are not at risk of inducing any infection. So there is no contraindication of vaccination. This is important to know. And third question, is there a risk to vaccinate PID patients who have, on top of PIDs, autoimmunity and or inflammation? And the answer is probably no. As far as we know, there has been a certain number of patients who have been vaccinated, and none of them, as far as I know, have developed a flare of their autoimmune or their inflammatory disorder. So there is broadly an indication to vaccinate PID patients. The good news being that this may be not as urgent because they are, for most of them, not at very high risk of bad disease, but still it's better to protect them and perhaps to protect also their family. So my conclusions are that with exceptions, PID are not at very high risk for severe COVID, and I mentioned what are the exceptions. They can be viewed, actually, the PID itself as a kind of comorbidity with age and lung disease, as I discussed. So PID patients can be vaccinated, and at the end of the day, they have to be vaccinated like everyone. There is no harm, and it will help. So they have to be vaccinated in due time. Perhaps their family should be vaccinated too. It doesn't harm either. And my last word would be to say that we are focused these days on COVID and vaccination against COVID, but we should not forget to vaccinate PID patients with the other vaccines they require. This is very important. Thank you for your attention.
Thank you very much, Alain, for this great overview. And you hit 2 birds with 1 stone because you've already answered many questions in your presentation, which is great. As a reminder, we'll take the questions after the next presentation. So we'll have the discussion after the presentation of Professor Elkayam. So I would like to invite Professor Elkayam now to take the screen, as we would say.
Okay, so thank you again for this kind invitation. And just a moment. Oh, no, something worked. something went wrong. Can you send the screen again, show my screen again?
We can
Yes.
see your presentation.
Sorry, there is some problem here. I cannot see the slides, I don't know why.
Give me a second, I will share the view again.
Oh, okay, now I think it's okay. So you see me, okay.
Okay,
fine.
A second.
So,
just a second. Sorry. Just a second.
Yeah.
Now, please
Yeah.
share your presentation.
Oh, okay, that's okay now.
So,
Okay,
are
that's
you
okay now. Yes. Yeah.
I cannot see it yet. Yes, now it's okay. You can see it.
Okay, thank you. So thank you again for this kind invitation, and I would like to share with you the Israeli experience in patients with autoimmune rheumatic diseases. I will start with a very brief introduction. As Professor Fischer has said, I think that this year, in fact, has been extraordinary in many ways, because it has changed our life from end to end. But on the other hand, it has brought also many positive issues, such as, for example, that there's a very quick development of vaccines, and we now have 4 vaccines that have been approved. And the experience that we have in Israel is with the Pfizer vaccine. And we all know that this vaccine has been the results of the phase 3 study including more than 44,000 healthy subjects were published in the New England Journal of Medicine. It included many patients with chronic disease, a very small group of patients with HIV, and it didn't include any patient with immunocompromising conditions. On the other hand, more than 40% of the patients of the subjects were above the age of 56, and it was very well balanced in terms of racial and ethnicity profile. And you can see here that more than 2,000 of the subjects included in this study were above the age of 65. And as Professor Fischer mentioned, the results were very impressive, and in fact, the effectiveness of the vaccine was 95% in this population. And it was across ages, sex, genders, ethnicity, and comorbidities. So this was quite impressive. And in fact, in terms of safety, it was found to be quite safe. So on December 2020, the Israeli Ministry of Health launched a national COVID-19 vaccination campaign, which was aimed at vaccinating most of the population, of the adult population, above the age of 16. And up to April 2021, more than 60% of the population has been vaccinated, which is very impressive, I must say. And I think Israel has been complimented about this conduction of this campaign. And Professor Fischer has already mentioned this paper, which has in fact confirmed the results of the randomized control study, but in a nationwide mass vaccination setting. And just to give a little bit more details about this study, which report the results from data from the Clalit Health Services, which is the biggest HMO in Israel, which includes more than 4.7 million patients. And in fact, during the period of December 20 to February 1, it compared between vaccinated patients and unvaccinated controls, which were matched by the demographic and clinical characteristics. And the study outcomes included the symptoms of COVID-19, occurrence of COVID-19, hospitalization, severe illness, and death. And as you can see, the study group included more than 526,000 persons. And in fact, this study, as it has been said already, has confirmed the effectiveness of the vaccine in real life. And in fact, it reduces symptomatic illness in 92% of the patients, hospitalization 87%, and severe disease in 92%, and this is shown here in these graphs. Infection, documented infection, symptomatic COVID-19, hospitalization, and severe COVID-19, and death. So the conclusion is of this real-life study was that, in fact, the results of the vaccine in real life are very similar to the randomized control study. So at the end of December 2020, the rheumatology community had to face, in Israel, the practical question whether to vaccinate all the patients, whether to vaccinate patients with lupus or with other conditions. We didn't have a lot of information about the safety of the vaccines in this patient, but we didn't have at all any information. And the group of experts, you can call that, the group of experts of the EULAR task force for vaccination, who formulated the update of the EULAR recommendations in 2019. We decided to formulate a point of view, some point of consideration, in order to perhaps give some answers, not really answers, but more thoughts of this group about vaccination against COVID-19. And first of all, concerning the status of the risk of contracting COVID-19 among patients with autoimmune rheumatic disease. So it seems to be similar to the general population, or at most mildly increased. And for most patients with autoimmune rheumatic disease, the course of COVID-19 is similar to the background population and is mainly affected by the presence of classical cardiovascular risk factors for severe COVID-19. However, there are some reports about the fact that the course of COVID-19 may be more severe in patients with lupus, in scleroderma, vasculitis, and perhaps congenital or acquired interferonopathies. It has also been shown that patients who are treated with prednisone at a dosage of above 10 milligram MMF, mycophenolate, and rituximab has been the course of this patient has been associated with the worst COVID-19 prognosis. In general, non-live vaccine, as you know, are recommended for patients with autoimmune rheumatic diseases. And in the midst of the COVID-19 pandemic, vaccination against influenza and Staphylococcus pneumonia should be highly encouraged. Sorry. Okay, as we have heard, RNA vaccines against COVID-19 are non-live vaccines, so they cannot provoke COVID-19 infections. And the feeling of this group was that in the view of the COVID-19 pandemic, the possible adverse course of COVID-19 in at least some groups of patients with autoimmune rheumatic disease, and the favorable severity profile of the mRNA vaccines in the general population, that these vaccines should be administered to patients with autoimmune rheumatic disease as recommended in the general population. And this statement is also valid for other non-live future vaccines that may be approved in the future. As for other vaccines, we thought that the efficacy of the COVID-19 vaccine may be reduced in patients treated with high-dose corticosteroid or rituximab. And for these patients, perhaps it should be preferable to administer the vaccine at least 6 months after the last infusion. But we were not very, of course, we did not have data about that. And we also recommended to perform studies on the immunogenicity and safety of COVID-19 vaccine in patients with autoimmune rheumatic diseases. So, and this is what we did, in fact. When we started with this massive vaccination campaign, we started also a study which aims was to evaluate the immunogenicity and the safety of the BNT 162b2 mRNA Pfizer vaccine in patients with autoimmune rheumatic diseases. In fact, this was a multi-center, well, this is the first time that we present the results of this study, and we have finalized the analysis during the last 2 weeks. These are preliminary results that maybe they may need fine-tuning perhaps, but they give a good impression, I think, about the immunogenicity and the safety of the vaccine. So this study was performed in 3 centers in Israel. In the Tel Aviv Medical Center, most of the patients were from one center, but also from the Carmel Medical Center and the Hadassah Medical Center. And we included 5 groups of patients with autoimmune inflammatory rheumatic diseases, rheumatoid arthritis, psoriatic arthritis, axial spondyloarthritis, lupus, connective tissue disease, mainly inflammatory myositis, and systemic vasculitis, including patients with large patients were consecutively recruited, and we excluded patients with who were pregnant. At that time, we excluded patients who were pregnant and with a history of past vaccination allergy. So this was the study design. We enrolled our patients. The patient received when they were evaluated in terms of disease activity at before receiving the vaccine. They received the first dose of the BNT 162b2 Mrna vaccine. After 2 weeks, they were contacted by phone for a side effect. After 3 weeks, they received the second dose of the vaccine, and 2 to 6 weeks after the second dose, they were evaluated for disease activity score, immunogenicity, efficacy, and adverse event. Oh, sorry, I don't know why they don't. No. Sorry. Okay. So the immunogenicity of the vaccine was tested 2 to 6 weeks after the second dose of the vaccine using the liaison SARS-CoV-2 IgG antibodies anti-spike glycoprotein. And concerning the efficacy of the vaccine, in fact, the subjects were asked for the occurrence of COVID-19 during the period between the administration of the first dose and the time when they came to the serological evaluation 2 to 6 weeks after the second dose. And in addition, up to the data cutoff, the patient files were reviewed for this purpose because in Israel, all the data is computerized, so we can see if the patient has a COVID-19 positive or not. So, concerning the safety of the vaccine, all the participants were contacted by phone within 2 weeks after the first dose of the vaccine, and they were asked to complete a questionnaire on side effects, which included local side effect at the site of injection, systemic side effects, and the same questionnaire was completed after 2 to 6 weeks after the second dose. We performed the clinical assessment of the disease for RA using the SDI and the CDI, for psoriatic arthritis using the DAPSA, the PASI for psoriasis, for the axial SPA, BASDI and ASDAS, and for SLE, the SLEDI, and for myositis and vasculitis, we mainly use the patient and physician global assessment. So the primary endpoint was to evaluate the immunogenicity of the vaccine in comparison with the healthy population, and the secondary endpoint was to evaluate the efficacy, the safety, and the effect of the different treatments on the immunogenicity of the vaccine, and also to assess the effect of COVID-19 vaccine on clinical disease activity. So these are the results. In fact, we recruited 710 patients with autoimmune rheumatic diseases and 124 LC controls, and you can see here the distribution within the different categories of patients are 273, 167 patients with psoriatic arthritis, and so on. Well, the age, in fact, these were quite typical patients. The group of patients with axial SPA was younger, and lupus, which is expected, and patients with larger vasculitis were older. And you can see here that most of our patients have received the flu vaccine, more than 70%, more than in some groups 80%. And this is because we really make a lot of emphasis on the vaccine in our centers. So what were the treatment used by these patients? You can see here that we have for glucocorticoid, we had 137 patients, methotrexate 182 patients, TNF-alpha blockers 180, most of them monotherapy, but there were about 30 with the combination therapy, IL-6 inhibitors 39, CD20 90 patients, abatacept 16, and JAK inhibitors 49, as you can see here, and IL-17 inhibitors 49 patients, and MMF 28 patients. So first of all, in terms of safety of the vaccine, you can see here the side effects after the first dose, and they were more or less similar after the second dose, so I will not show them. You can see here that in fact there were even perhaps less local side effects in the patient with rheumatic disease than in the healthy population, but you can see here that about 55, it's similar than what was reported for the Pfizer study. 55% of the patient rheumatic disease local pain, and 69 in the healthy population. So this was significant. For the rest of redness, swelling, itching, it was similar, and as you can see, it was only a few patients. If concerning systemic side effect, the same. In fact, it was really not very prominent and really not concerning. And there are other side effects. I just want to mention some adverse event of special interest. There was one patient who developed uveitis. It may be not related, of course, but I just want to mention that. One patient who developed pericarditis, and we had 6 patients who developed herpes zoster, which was quite surprising, I would say, but this is what we had. And unfortunately, we had 2 patients who died a few weeks after the second dose of the vaccine. I'm not sure that it is related to the vaccine. One of the patients was a patient with ANCA-associated vasculitis who was in remission for 3 years. And 3 weeks after she received the second dose of the vaccine, she developed a fulminant picture of vasculitis, and with, in fact, and she died of sepsis. And the second patient was a patient with psoriatic arthritis who suffered from many cardiovascular risk factors and died from MI. In terms of the effect of the vaccine on disease activity, you can see that, in fact, as a group, there was no real worsening of different parameters of disease activity. This is the C-die, for example, in RA patient, the S-die, which was quite stable. For psoriatic arthritis, the DAPSA, it was a little bit increased, but it is not really significant. This is the PASI, which was really not affected. The ASDAS for axial SpA, and the SLEDAI, which really didn't change in this population of patients. When we evaluated the data, the clinical scores in terms of the categories, I mean, how many patients worsen, moved from low disease activity to moderate disease activity, etc. So about 20% of the patients had some change in the status of the S-die, for example, but 80% were stable and even improved. Concerning the DAPSA, 16%, but all the rest improved or even remained stable, and there was no change in the PASI. The ASDAS, 15% was a worsening, but the rest improved or remained stable. And for SLE patient, in fact, only 5% had the worsening of the SLEDAI. So the main results, what was the immunogenicity of the vaccine? So you can see here that, in fact, all of the our healthy controls developed an adequate response. I mean, the mean titer of antibodies was 218. A result above 15 is considered to be positive, and 100% of the healthy controls were positive. The group of the patients with autoimmune rheumatic disease, in fact, as a group, they had a good response. You can see here that, in fact, the mean titer of antibodies is 132 plus minus 91. So, in fact, it is appropriate, but it was much lower than the healthy control, and this was significant. You can see here the 100 patients of the 100 of the healthy controls had a positive had the antibodies above the range of 15, and 86 in the group of patients with autoimmune rheumatic disease. And you can see here the distribution. You can see that for patients with psoriatic arthritis and axial SpA, it was like in the healthy controls, more or less, but it was much reduced for the group of patients with RA, but mainly for patients with connective tissue disease, myositis, and this is probably related to the use of rituximab, and I will show that later, and also in patients with ANCA-associated vasculitis for the same reason. In terms of efficacy, we had no cases of COVID-19 among this group of 710 patients, but we had one of the control who developed COVID-19. He had developed very mild COVID-19 and completely recovered from it. He was not hospitalized for that. So in terms of the effect of treatment on immunogenicity, for all the treatment groups, the titer of antibodies was significantly low in comparison with the healthy controls, although the levels were adequate for most of them. And in fact, in a univariate analysis, the use of rituximab, glucocorticoid, MMF, and methotrexate significantly reduced the titer of antibodies. When we performed a univariate analysis of the logistic regression predicting seropositivity, we could show that, in fact, TNF-alpha, IL-6, and IL-17, when they were administered in monotherapy. In fact, more than 97% of the patients had protective antibodies. For JAK inhibitors, it was a little bit lower, but still acceptable. I mean, between 9 to 14% were negative, and mainly the negatives were those who received the JAK inhibitors in combination with the methotrexate. But there was a significantly reduced proportion of seropositive patients, yes, it should be seropositive here, in patients with myositis, ANCA-associated vasculitis, RA, and lupus, in patients with older age, and CD20 inhibitors, rituximab, in fact, severely affected the development of antibodies. Only 41% of the patients treated with rituximab developed antibodies. And for abatacept, about 63%, MMF also only 64%, and methotrexate 84%. And of course, concerning rituximab, the development of antibodies really was related to the time between the vaccine and the last infusion of rituximab. As you can see here, that after 400 days after the in fact, the median survival, if you can call that, 50% of the patients had a possibility to have positive antibodies after 354 days, almost a year. So, and this table, in fact, summarizes the unadjusted and adjusted logistic regression models, and you can see here that age about 65 was associated with a reduced seropositivity, RA, connective tissue disease, ANCA-associated vasculitis, methotrexate, and rituximab. And when we adjusted it to methotrexate, rituximab, and age, we could show that, in fact, the results were, in fact, significant for the combination of abatacept with methotrexate, and also for MMF, as you can see here. So, sorry. So in conclusion, in this group of patients, of more than 700 patients with autoimmune rheumatic disease, we can say that the vaccine is safe and immunogenic in most patients. It doesn't significantly affect disease activity. The level of immunogenicity is significantly reduced in patients in comparison with healthy patients. Also, although seroprotection was achieved in most patients, but well, we don't know what will happen in the long term, of course. And seronegativity is associated with older age and the use of rituximab, MMF, and methotrexate. So this is all, and thank you very much for your attention, and I will be happy to a question now.
Thank you so much, Professor Elkayam, for the great presentation. Lots of new data as well, so we are very grateful to you. And maybe I will ask now Professor Fischer to join us again. And we have received quite a number of questions, so my task is to go through all of them, and then hopefully we can take many of them. Maybe I will start with one to you, Professor Fischer, from one of our participants. Do you think patients with monogenic interferonopathies could be particularly at risk of having a disease relapse if vaccinated, given that these vaccines may trigger an interferon production in those children?
Yeah, I think this is a very important question, and the rationale is very strong. As far as I know, but perhaps Professor Elkayam may also contribute to that question, because I think the question is in between both of us. As far as I know from my colleagues at Paris at Necker Hospital who are taking care of such patients, and from potential reports from the literature, I haven't seen so far, not heard and not seen any reports of such induction of a flare of an interferonopathy caused by the COVID infection. So is it because the numbers are low and the chance have been limited, and because some of these patients are being treated by molecules that block or at least partially inhibit the response to interferon? I don't know, and maybe we should not probably take a definitive answer to that question and remain cautious about it. But at least there hasn't been any drama I'm aware of in the context of these patients with interferonopathy.
Thank you. And I don't know, Professor Elkayam, do you want to complement the response or?
Well, I agree with you. I think that in general, it does not induce any flare of the disease. There may be some patients in whom it may induce some flare. It's very difficult to say. Some of the patients also stop their treatment around the vaccine. It's by their initiative, and it may be one of the reasons why too. And well, I think that like any trigger, it may happen, but as a group, I don't think that that the group of patients with rheumatic disease are more prone to a flare after the vaccines or etc.
Thank you so much. I have another question for you, actually, Professor Elkayam. Someone is asking, with all the research going on to learn MAS and cytokine storms due to COVID, is there any possibility to find a cure for systemic juvenile idiopathic arthritis?
Oh, wow. You are asking me? Well, I don't think that I can answer this question really.
Okay, and I don't know if there's another comment from Alain. If not, we will
try. Maybe the only thing I would like to say that, as far as I understand, juvenile arthritis on one side and COVID on the other side, it looks to me, despite there are a few common inflammatory markers, it seems to me still there are very, very different diseases. So I'm not sure we may deduce from studies in the context of COVID new treatments for systemic juvenile arthritis.
Thank you very much, Alain. And now I have a question from one of the patient representatives, still for you, Alain. Is there any data on COVID vaccination in CGD patients focusing on inflammatory factor of the disease?
I think it's a little bit too early to have data because I don't think many patients have been immunized so far. Well, what I can tell is, again, but just a few cases. I haven't heard about bad events or bad consequences of vaccination. I would be surprised that the vaccination would be inefficient in these patients, but of course, this has to be checked.
Thank you very much. And now for Professor Elkayam. So someone is asking, as we discussed during the EULAR viewpoint, I would like to ask whether the advice to wait 6 months for patients with rituximab is reasonable in a pandemic situation, and whether it would be more reasonable to advise vaccinating as soon as possible and rather follow up with booster vaccinations later on in order to add a potential B-cell response to a hopefully already induced T-cell response.
Yeah, well, I think it's a very good question, of course. Well, first of all, we have shown that in fact, in terms of humoral response, it is very severely impaired in patients with rituximab. And during the first 6 months, I mean, most of the patients do not develop antibodies. It doesn't mean that they are not protected. I mean, as Professor Fischer has shown us in patients with immunodeficiencies, there is these patients may have cellular immunity. And from this point of view, it may protect them. And indeed, we are now performing some studies on trying to evaluate the level of cellular immunity in these patients who have negative antibodies. I think that, well, now that I think that at the beginning of the campaign, we did not have any information about the safety of the vaccine in patients with autoimmune rheumatic diseases. We saw that the vaccination in patients with rituximab probably will not succeed, and we felt that we may in fact give a vaccine that we do not have any safety data on it in our population of patients, and that perhaps the chance that it will provoke any humoral response are very low. So that's why we thought we were very conservative in our points of consideration. I think that now, despite the fact that they will not have humoral response, once we'll have more data about the cellular immunity, I think that we will be able to answer this question, whether to vaccinate this patient. The concern of the booster, I think that if the patient is still treated with rituximab, I'm not sure that the booster will help in terms of humoral response. I mean, in terms of cellular response, it may be useful, I don't know. But in terms of humoral response, I don't think that it will help. So So that's where we are now. And I know that there have been some, for example, the ECR recommends to vaccinate any patient since these patients with rituximab are at high risk of contracting severe COVID-19. I think that we do not really have an answer for that. I think that we feel more confident about in terms of safety to administer the vaccine. Now we must be aware of the fact that in terms of humoral response, probably most of these patients will not have humoral response.
Thank you very much for the comprehensive answer, despite the complexity. There is another question. Since there is here a cell-mediated immunity to RNA vaccine, what is your opinion on the strategy to delay the second dose to 2 or 3 months to vaccinate more people in the shorter time as possible? I guess this is also a question that both of you could have a viewpoint on. Maybe starting with Alain.
Yeah, the idea is around, actually, that's what the people in the UK do. And also, I think, in French-speaking Canada, but not in the rest of the world, as far as I know. I am not very much in favor of this idea. I understand the point that to try to, of course, to deliver vaccine to more people. But of course, sooner or later, you will have to deliver the second dose. So at that time, you will slow down the campaign. So it's a transient gain. And in terms of immunization, we do not have data in terms of efficacy of delaying the second dose. We know that the antibody response after the second dose is much better than after the end, after 21 days after the first dose. So it's very likely that people in between dose 1 and dose 2, so during X weeks, will be less well protected. And this might not be so important for young people, but if you vaccinate people who are sick, like the ones we are discussing about today, or elderly people, this may matter. And especially in the context where we have many variants circulating over the world. And we know, and there is a recent paper published in Cell that shows that the quality of antibody response against the so-called South African or Brazilian variants after 1 dose of an RNA vaccine is very low. And whereas it is better, it's not perfect, but it's much better after 2 doses. So there is a risk associated with delaying the second dose. So I will personally stick, this is the case in France as in many countries, to stick to the original regimen of ideally of 3 to 4 weeks.
Thank you, Alain. Thank you very much. And maybe I know the time is not on with us at the moment because we are 2 minutes past, but maybe a last couple of questions, if you allow me. And maybe starting with one again from a PID patient representative about the how to articulate the vaccine administration to PID patients with regards to the IG infusion. Is there a specific timing that should be followed to be optimal, or doesn't it matter? Because we heard different viewpoints from the patient community on this. What's your comment?
Well, first of all, there are no data. We can just speculate. There are 2 points. One would be, is there a risk that the antibodies contained in the immunoglobulin preparation will neutralize the vaccine? This is these days unlikely because there are no antibodies against the spike in the vaccine, in the immunoglobulin preparation. So at least for the moment here, there is not a problem. There is no problem. The second one that maybe discussed is the reactogenicity of both the immunoglobulin treatment and the vaccination, and maybe it's not a good idea to combine them at the same time. So I would not suggest to do the very same day, the immunoglobulin administration and the administration of the vaccine. But apart of that, up to now, I am not sure there is too much to be concerned about it.
Thank you, Alain. And I will finish by a question that's again addressed to both of you. Are there any data on the patients who develop COVID-19 after vaccination in order to see or identify potential risk factors of vaccination failure?
Well, I think that probably there are some patients who, first of all, older patients may have a lesser response to the vaccine. That's one. Although most of them they really have a good response, but there may be some patients. I don't think that we have really data about the patients that, and well, we all know that the patients who are vaccinated and develop the COVID-19, they have much milder disease. So it may be a question of, you know, the immunogenic response in general. And of course, there maybe, as we have shown, some treatment that may impair the response. So you must be aware of that.
In the context of primary immunodeficiencies, up to now, I'm not aware of any case, but this might happen. But I am aware that of patients who are immunodeficient because they have been transplanted and are receiving a continuous immunosuppression. Those people do not make well antibodies following vaccine, and there are some cases, including very rarely, but including severe cases of COVID in transplanted patients. So that these days there is quite a discussion, and actually even a indication of giving them a third dose of vaccination, but it's a very special situation.
Yeah, indeed. And well, I mean, it's a side point, but there are also some talks about potentially the COVID-19 antibodies showing in immunoglobulin preparations in the future because of the donors pool. So it'd be interesting to follow that as well.
Yeah, in due time.
In due time, indeed. So I think we have now reached the end of this ERN-RITA webinar. I'd like to thank all of you for your participation, and of course a huge special thanks to both Professor Fischer and Professor Elkayam for their excellent contributions today. We really appreciate it. If you have a minute to spare, we encourage you to share your feedback on the webinar. There will be a link appearing on your screen as soon as the webinar closes. You can provide your feedback there. Otherwise, on Monday next week, you will receive a follow-up email with the link to the recording of the webinar, which, by the way, will also be posted on the ERN-RITA website. So by all means, if you know, colleagues who were interested but could not attend, they can view the recording of the webinar. So that will be in the email as well on Monday. So for now, I would like to thank you again. Stay safe. See you next time, and have a good weekend, everyone.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.